Welcome, my name is Luis Paez, and the topic of today is immunotherapy-renal cell carcinoma and ribavirin for chronic hepatitis E virus infection transplant recipients. Let's start with the definition. Renal cell carcinoma is a kidney cancer that originates in the lining of the proximal convoluted tubule in the most common type of kidney cancer in adults. Renal cell carcinoma becomes metastatic renal cell carcinoma when it spreads beyond your kidney to your lymph system, bones, or other organs. Systemic therapy refers to any type of cancer treatment that targets the entire body. For example, chemotherapy, the most common form of systemic cancer treatment.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help destroy cancer cells. Cytokines are the artificially engineered versions of natural proteins that activate the immune system, and the ones most often to treat kidney cancer are interleukin-2 and interferon alpha. The targeted therapy works by blocking growth of the new blood vessels that nourish cancer cells or downplaying important proteins in cancer cells that help them grow, or both. Clinical response rates with chemotherapy, either monoagent or combination, are usually less than 15%. Renal cell carcinoma is not very sensitive to radiation, and radiation therapy is more often used to palliate or ease cancer symptoms in case of cancer spread. For more information about list of expert doctors, hospitals, and ongoing clinical trials, please visit www.expertdocs.com.
Okay, let's continue. With applications in medicine. The treatment of metastatic renal cell carcinoma (MRCC) has progressed toward the goal of transforming cancer to a chronic rather than a lethal disease. This has been particularly highlighted with the advances in the systematic therapy that have come forward in the past decade. Prior to these advanced, patients with MRCC We're left with relatively few options, as MRCC is known to have low response rates to traditional cytotoxic therapy, with more than 70 agents being tested and response rates less than 10%. Pros and cons. Pros. Therapy with elagalicid is for oral use. It is only necessary to control the exit time for taking it without the help of professional. Cons. Replacement therapy is necessary to decrease the hypoestrogenic effects, especially the decrease in bone mineral density.
My name is Dr. Kalen Silverberg. I'm with the Texas Fertility Center in Austin and in San Antonio and New Braunfels. And I'm here today to talk about elagolix, which is a brand new medical treatment for endometriosis. The exciting thing about this is the first new drug that's been approved by the Federal Food and Drug Administration for the treatment of endometriosis in over 10 years. To date, what we really have when a patient has come into the office until a few months ago, we could offer her birth control pills. We could offer her non-steroidal anti-inflammatories like ibuprofen. We could offer her a drug called Depolupron, which is given by injection. Very effective. It takes away endometriosis pain. It stops her periods. But the downside is it can cause hot flashes, vaginal dryness, up to a little bit over 6% bone mineral density loss. But it is very effective at pain control. The biggest problem is that when you inject that medicine, it's in your system for between 1 month and 3 months, and there's nothing you can do about it. Now we have a brand new drug that's given as a pill. Patients like pills a lot better than they like injections. The side effect profile is substantially better. So whereas with Depolupron, almost everybody stops having periods, with elagolix, only about 25 to 40% of patients stop having periods. The side effects are also substantially less in terms of hot flashes, vaginal dryness. Again, as a pill, it can be taken every day, once a day, or it can be taken twice a day for 6 months for more severe cases. But if you don't like the side effects, you can stop it and the drug is gone within 24 hours. So it's really a very effective, brand new, novel treatment for endometriosis, and we're very excited to have the opportunity to use it and work with it in our patients.
Issue applied in Ecuador. Bleeding for fibroids in Ecuador is one of the main causes of gyneco-obstetric care, either because of the anemia that causes long-term bleeding or because of the risk of infertility in young women. Treatment is focused on reducing bleeding. For this, hormonal therapy is used, including GnRH antagonists. At the same time, if the pharmacological alternatives do not improve the picture, progress should be made with surgical treatments such as laparoscopic myometry and finally hysterectomy.
Many women have uterine fibroids.
Uterine fibroids are benign, non-cancerous tumors that form within the uterus from an overgrowth of connective tissue and smooth muscle.
Dr. Erica Navel-Kepsel says symptoms include heavy bleeding, anemia, difficulty emptying the bladder, and pelvic pain or pressure.
We do have a variety of options to help us treat uterine fibroids.
Treatments range from medication to surgery. One less invasive option is uterine artery embolization. Doctors access the fibroids via catheters inserted through a small artery in the groin or wrist. Once there, they fill the fibroid with contrast to make sure they're in the right spot. Then they deliver small particles that plug up the tiny arteries feeding the fibroids.
Once these tiny arteries are cut off or plugged up, the blood supply to the fibroid is gone and the fibroid shrinks.
For the Mayo Clinic News Network, I'm Vivian Williams.
Okay, let's continue with the conclusion. Systematic therapies have shown an important advance in the management of the patients with metastatic renal cell carcinoma. In spite of this, there are no standardized protocols for their use and it depends on the professional who use them. So there is still a lot of work on studies of their long-term results must be continued.
Hello, my name is Dr. David Archer, and I will be discussing the results of this Phase 2A proof of concept study investigating the gonadotropin-releasing hormone antagonist elagolix in the management of heavy menstrual bleeding associated with uterine fibroids. Uterine fibroids are the most common benign tumors affecting reproductive age women, and although patients are often asymptomatic, the disease can present with heavy menstrual bleeding, which is the primary indication for hysterectomy. These tumors are estrogen and progesterone dependent, and hormonal modulation is a mainstay in the management of the disease. However, there is no FDA-approved long-term treatment for heavy menstrual bleeding in women with fibroids in the United States. The serum levels of estradiol and progesterone are tightly controlled by the hypothalamic pituitary axis. Hypothalamic gonadotropin-releasing hormone is secreted in a pulsatile manner from the hypothalamus. After binding to receptors in the anterior pituitary gland, the two gonadotropins, luteinizing hormone and follicle-stimulating hormone, are secreted into the peripheral circulation and stimulate the ovaries to produce estradiol and progesterone. Elagolix is an orally active non-peptide gonadotropin-releasing hormone antagonist that leads to a dose-dependent suppression of gonadotropins and sex steroids. This hormonal suppression is rapid and reversible, and the degree of suppression can be controlled by varying the dose. The objective of this study was to evaluate the safety and efficacy of elagolix versus placebo with a combination of low-dose estradiol and progestogen as add-back treatment. Reproductive-aged women with a diagnosis of heavy menstrual bleeding due to uterine fibroids were treated with various doses of elagolix with or without add-back versus placebo for 3 months. It is worthwhile to note that this is the first study to evaluate estradiol and progestogen add-back therapy in combination with either a gonadotropin-releasing hormone agonist or antagonist in women with uterine fibroids. The menstrual blood loss, measured by the alkaline hematine method, decreased in a statistically significant dose-dependent manner compared to placebo with the 300 milligram, 200 milligram, and 100 milligram twice-daily doses of elagolix. The add-back did not alter the decrease in menstrual blood loss compared to elagolix alone. Given its mechanism of action, it was not unexpected that hot flushes were the most common adverse event associated with elagolix. 56% of patients in the placebo arm experienced an adverse event in this trial, with higher rates of adverse events in all of the elagolix treatment arms except one of the add-back regimens. Add-back regimens appeared to decrease the rate of hot flushes as well as the discontinuation rate. In conclusion, elagolix is an oral non-peptide gonadotropin-releasing hormone antagonist that suppresses the pituitary-ovarian axis and significantly reduced the amount of menstrual bleeding in the study participants. Of the study dosing regimens, the 300 milligram dose taken twice daily had the greatest efficacy. Indeed, this dose was selected for the subsequent Phase 2B and Phase 3 studies. Hypoestrogenic effects were seen in a dose-dependent manner. However, the add-back regimens reduced the extent of hot flushes with minimal impact on bleeding. Consequently, elagolix is a promising medical treatment for heavy menstrual bleeding associated with uterine fibroids that warrants further study in Phase 2B and Phase 3 clinical trials of greater duration.
Okay. Now, let's continue with the Ribavirin for chronic hepatitis E virus infection in transplant recipient. Definition: Hepatitis E virus (HEV) is an icosahedral non-developing single-stranded RNA virus that is approximately 27 to 34 nm in diameter, 2 or 6. It has been classified as a single member of genus Epivirus in the family Epiviridae. The antiviral drug Ribavirin can clear chronic hepatitis E (HEV) in solid organ transplant recipients, researchers reported. Pros and cons. Pro. Ribavirin's monotherapy is a safe treatment option for HEV infection. Cons. The optional dose of ribavirin for the treatment of chronic hepatitis E remains to be determined. Ribavirin can cause anemia, shortness of breath, fatigue, chest pain, and a heart attack. Can harm a fetus too. There is also the potential of severe depression and other psychological side effects. And conclusion. Multicenter studies showed that ribavirin as monotherapy may be effective in the treatment of chronic HEV infections because it inhibits replication of many RNA and DNA viruses. Thank you.